Philippin and myself. And I will have a look at this from, I could say, practical perspective, but not so much from a clinical perspective. And he will then have a look at this from a more clinical perspective. So, when looking at an electrophysiological recording, what I mean is basically you get a report sheet, something like this, with a printout, or you get it electronically maybe, which shows the outcome of an electrophysiological test or a series of tests. The question is, what should you look at? What should you look out for? And this is what I could come up with. The first point is actually to familiarize yourself with how the data is presented, including axis scaling and so on. And the interesting thing is that each manufacturer has a different idea of how to present the data. And this can be extremely different. And speaking about myself, when I get a result sheet from our lab, I exactly know how it looks like, and in many cases I just look at it briefly and I know what's going on and whether this is normal or not. Yeah, and if I get something from a different lab occasionally because someone is asking for advice, for example, or I want to compare the present data to data that's been recorded somewhere else earlier, then I really have a very hard time understanding this data simply because it's plotted differently, it's presented differently, summarized differently. So that's a very interesting point by itself. And also, even if you know the general layout, sometimes things like axis scaling change because a person has an unusually large amplitude and it doesn't fit into the normal window. Basically, then the axis is rescaled, maybe depending on what the software is doing. So it's good to have a look at all this. Then one thing which is actually most important, I think, is to look out for artifacts and technical problems. And in our department, I always tell the people, like the ophthalmologists in our case, in principle, you should be able to interpret all these curves yourself. You're an ophthalmologist, you should know what's going on there. Yeah? The challenging part that you might not be able to do, and I understand that you can't do that maybe, is understanding the technical basis and therefore understanding the artifacts and the technical problems that might manifest in these curves. And this is, I think, an important point that you know, is that clean data or is there something in there that shouldn't be in there? And then, of course, the question how to deal with it. Sometimes one can try to get rid of artifacts using additional analysis options. Or if you're like doing this, you could export the data and manipulate it yourself with MATLAB or R or Python or whatever. Yeah. But you, of course, need to know what you're doing, how this impacts the data, because whatever you do with your data, and usually don't just remove artifacts and signs of technical problems. You also do something to the real data, to the physiological part of the data, and you need to know what you do. Then usually you should have reference ranges to know what is normal and what is not normal, and you should understand these, and ideally they would be part of the report sheets. And then comes the next major point. I mean, all of them I think are important, but the next kind of traditional major point is to evaluate the data in terms of the different functional components of the visual pathways, so that you can actually say, okay, this is that type of cells, for example. And then I would suggest to double check things. Earlier I said if I get a report sheet from our own lab, I just have to look at it briefly and I see that it's normal, for example. But occasionally it turned out that I was misled and it looked perfectly normal at the first glance, and I really had to look closer to see that something was not normal. So it's worth double checking everything in the end and really going back and seeing how a peak, how big it is if you by looking at the axis and where it is in timing and so on. And then, of course, it's important to bundle this information that you get out of the electrophysiology measurements with everything else you know about the patient. And that's already been said before, that usually it's one piece of a bigger puzzle, and there are not many diseases where electrophysiology tells you exactly this is the one disease. Normally it tells you about which structures are affected, which cell types and so on, and there could be several diseases that show a similar result pattern. And then finally, of course, try to reach a diagnosis, or sometimes maybe the question is to judge progression or remission. So let's first, I won't go through all these points in detail, but let's first have a look at artifacts and technical problems. This is maybe a perk, not maybe a perfect one, but technically it's a good one. Physiologically, maybe it's not fully normal. And this is a normal VP. And here something has changed. What you see is this strong zigzag effect here. And that's strong 50 Hertz mains interference. As you know, the electricity that's coming in from the power plant which is in the wires in the wall and also in the cables leading to the equipment, that's alternating current, alternating at 50 Hertz I think in most of Africa also, and there are some parts of the world where it's 60 Hertz. And these produce a magnetic field, and that magnetic field is also alternating and can be captured by the wires of the electrodes, for example. And then you have basically it induces a voltage in the electrode wires, and you measure this alternating signal as part of what you're measuring. And so this is not something that the visual system of the patient does, it's simply coming from the outside. And here you have something which looks like it's going upwards from here to here. And that's what we call a trend artifact. These trend artifacts can come from various sources. Sometimes simply the kind of the baseline of the signal has low fluctuations. Or we capture trailing ends of blink artifacts. So if people do eye blinks, usually we try to eliminate them in the sense of we don't use that kind of segment of the signal where the eye blink occurs, but sometimes somehow it persists a bit and we don't capture or we don't cut it out fully, and then we might have some remaining parts of it in the signal. It's usually best to find the real source of the problem and to eliminate it. The problem is it's not always possible. Sometimes simply for some reason you don't find the problem in that moment, and you can imagine you have this patient sitting there and the patient is getting a bit impatient maybe, or it's a child that cannot sit still for a long time. And sometimes you have to accept that the signal is not as good as you wanted to have. But of course, generally it's best to improve the signal rather than dealing with it later on. And some machines have a button somewhere which says 50 Hertz notch filter. And generally I would try to avoid this button if it's at all possible, at least during the recording, because it's probably then on the analog side of the whole system. So the signals first are analog signals, of course, and they're digitized at some point to be stored and later to be analyzed. And filters on the analog side, they are never fully sharp. So if they say they are a 50 Hertz notch filter, you cut out more than just 50 Hertz. And also, it has an effect on the timing of the signal. And therefore, it's best to avoid it if possible. Yeah. Let's see what comes next. Then if you get a recording that looks like this, and maybe you see that already during the recording if you do it yourself, but if you don't do it yourself, then of course you have to accept how it is. What one wonders here is there really no signal at all? Or is there maybe a technical problem? And that gives you a feeling of uncertainty, because sometimes there can be technical problems which simply mean no signal is measured, and then you don't feel good about judging this. If you see eye blinks in here, which could be like deflections somehow, often relative big deflections, then the good thing is the system is measuring something at least. So it's not a proof that it's measuring everything correctly, but at least you are more certain that it's measuring something, because at least it's measuring the eye blinks, which come because the eyes have because of the retinal epithelium, they have a positive and the negative side, and if the eye moves, this changes the electrical situation for the electrodes, and therefore they produce, or basically they capture electrical changes during eye blinks. And so this what we see here is an ERG trace, moderate flash strength probably, and that would be the same signal but also with a mains interference. And here you have a flash ERG, full-field ERG signal, the A wave, and this is the B wave here. And then you have this bump here, and you might wonder, is this a second B wave? Maybe the person is producing two B waves. No, it's not. This is actually a part of an eye blink artifact. And some people do eye blinks rather quickly after the flash comes, like a reflex basically. The eye tries to protect itself and doesn't like the flash, so it's doing an eye blink. And this is a moderately fast person in this respect. Unfortunately, sometimes, not very often, luckily, there are people who do eye blinks already, like here. And then, of course, you have a very hard time distinguishing eye blinks from the actual B wave. Then you have to guess a bit or kind of develop a feeling, is it just an eye blink or not? And it's difficult to disentangle it then. But it's good to be aware, at least, that it might be an eye blink then, and not just take it as an abnormally large B wave. And sometimes you can judge that if you compare different flash strengths that are collected through the protocol and see how this develops. Sometimes there are hints towards that being eye blinks. And to say a bit more, and also to be a bit redundant partly, it's always best to avoid artifacts in the first place. It's not always possible, especially if you're not doing the measurements yourself, but just get the report. Artifacts might mislead automatic analysis functions of the software, because very often the software does not have the intelligence to say, okay, this is an eye blink. It simply takes maybe the highest value in a certain time range and says, okay, this is my peak, and this peak might be an eye blink and not the B wave. Yeah, so it's always important, if you get numbers, to look back to the actual curve and see whether the numbers make sense or are just read from some part of the curve that, or where they shouldn't be read from. And of course, human evaluators might also be misled. And depending on the test type, optic media might play a role, like refractions and opacity. Opacities, we have heard a bit about that already in the preceding video presentation. And yeah, of course, for those tests that rely on pattern stimuli, refraction has some relevance. Opacities might play a role not only if no light is coming through, but for example in multifocal ERGs, where we want to have localized responses. If a cataract gives you a lot of stray light, then basically the flash that's coming from one stimulus patch produces stray light that scatters all over the retina. So basically the response that you get is then not fully localized anymore from that one patch, but rather the stray light stimulates the full retina, so get partly something like a faint Ganzfeld response because of all that stray light. And that's, of course, something that the analysis software doesn't know. So it might give you responses that are not so perfectly localized, even though it shows it as localized responses. If the people have oil or gas fillings in the eye after vitreous surgery, for example, this might affect electrical properties of the eye. So the signals from the retina might not get through the vitreous anymore. And this is, of course, something that might cause a problem. So it's worth looking into the recent patient history, whether they had some surgery with fillings. So understanding reference ranges is also something that I quickly wanted to look at. This is how we plot our results. We also add additional sheets with the actual curves so that everyone can look at the curves, but that's kind of the summaries. And our doctors always tell me they only look at that, and then I always tell them also look at the curves, but they don't do that. And nevertheless, I mean, the purpose of this is, of course, to give you a quick overview. And the important part here is basically that what I want to show you is that there are reference ranges. These are these dashed lines here. And here, in the case of the photopic response, it's plotted as a rectangle with the time here and the amplitude here. And fully normal people should, of course, be in the reference range here and within here. So these are different flash strengths that are plotted on the x-axis. And so, yeah, and here we have the BA ratio, which is the ratio of the B wave amplitude divided by the A wave amplitude. In the previous presentation, we have seen the electronegative ERG, where the B wave doesn't reach the zero level anymore, it remains under the baseline basically. Sometimes this is not as clear as in these examples that we had seen, but still the B wave is a bit abnormally low, and you can quantify that through the B divided by A ratio. And for that we also have normal values, at least for a certain range. So these reference ranges are important to give you an idea of whether a signal is roughly how we would expect it or very much away from the normal range. But you should be aware that how these reference ranges are constructed, they represent 95% of the reference population, so-called normal people. I mean, the word normal is maybe avoided, or people try to avoid it because it has some connotations that they don't want to have. But anyways, it's just 95%. So that means every 20th person who is healthy should have a value outside this range. So, of course, you don't know which one it is, yeah, or whether that specific person is healthy or not. But generally, if everything else is looking normal in that patient, just the fact that electrophysiology is maybe slightly out of the reference range doesn't necessarily mean that there's a pathology. That's simply how statistics work. And also, one needs to be aware that most diseases start with a relatively mild stage. Yeah, it's rarely the case that from one day to the other you have kind of the most strongest stage of that disease. Yeah, normally it starts with some mild stage, and if you look at this, I mean, it's a very very basic sketch here. If this is the distribution of values you would expect from a healthy person, then in early stage, the distribution of values that we would expect from people in that early stage doesn't differ much from the healthy stage. There's a huge overlap, and the early stage person might give you a value somewhere here, and this is still in the reference range collected from healthy people. And of course, if then someone has a value in the kind of more towards the edge of the reference range, you might say, well, maybe it was someone who, when he was still healthy, had a relatively large value, and now it moved a bit within the what's considered the reference range, and still, but it just hasn't crossed the line yet. Yeah. That could be a possible interpretation if there are other signs of disease, maybe. And then you would say, or could say, at least in your mind, have the idea, well, he's already towards the edge, hasn't crossed it yet, but maybe it's an early sign of disease. But that's something, basically, you cannot easily put it into hard numbers. Yeah, it's more like you have to know all these uncertainties to interpret it properly. And of course, then when it gets to the late stage, maybe that distribution is not overlapping much anymore with the reference. So reference intervals, of course, provide important information, but they need to be interpreted cautiously. Occasionally, I haven't shown that, but there are a few points that I haven't shown. A peak time increase despite normal amplitude might be the first sign of disease. Sometimes simply processing is a bit slower, but still the amplitude is pretty high. Yeah? And we see that sometimes in, for example, photopic ERGs. Of course, it's clear that tests also have some retest variability. So if you measure the same person several times, you will see that it varies a bit. That different sources for that, of course. I mean, different people putting in the electrodes are slightly different, or simply on that day something, I mean, the physiology also varies a bit, yeah. So you cannot expect to get exactly 100% the same value every time, but that's the case with all measurements. I mean, it's the same with visual acuity or any other thing that you would do. And there's, of course, inter-individual variability, which is the main factor in the width of these reference ranges. That can partly be factored out if you have a baseline measurement. Of course, you wouldn't send everyone in the whole population to get a baseline measurement, but it can be useful in some cases if you know that patient gets certain drugs, that you say, okay, we get a baseline measurement because there's some likelihood that the drug will affect the eyes, and then we know how it looks in that patient when the eye was still okay, and then it's easier to compare it to that. But it's of course a question of how much effort do you want to put in all that, and who pays for it, and all these things. Yeah, and then comes that point, kind of the most important point from a clinical perspective. evaluate the data in terms of the different functional components of the visual pathways. We have seen this already. Basically, we have a dark adapted ERG typically as part of the ICEF standard, which gives us a rod response, and we have the with a faint flash. This is with a stronger flash, still dark adapted. Then we get a nice A wave and a B wave, and the A wave is measured from the baseline. The B wave is measured from the trough of the A wave up to the tip of the B wave here. And one can also record oscillatory potentials. I don't want to go into detail there, but this is just to recap that what we have already seen. And as maybe a bit of help for memorizing it, you can think of B wave, the B, as bipolar cells. I mean, that was not the reason for labeling it B wave, but it kind of helps to memorize it maybe. And similarly, the photopic responses, where you also have an A wave and a B wave, and the flicker response, which, as we have heard, is an even better indication of the photopic mechanisms. And one really important thing, I think, is that one needs to think of all these electrophysiological tests as kind of something that tracks the chain of processing, the chain of activation through the visual pathways. And that's already something that we've heard before, that if something early in that chain does not work well, then this will affect what we measure at a later part of the chain. Which doesn't mean that this is necessarily completely useless to measure here, but we need to know that effects could come from earlier stages. And so, different response components relate to different retinal and cortical structures. That's clear. Mostly they follow an activation chain with a few parts branching off, but still these parts branching off have some earlier stages. Sometimes you can guess effects at earlier stages from characteristics at later stages. For example, if you look at the VEP, a VEP is characterized, if you, or could show a delay in peak time. And normally the rule is a delay in peak time might mean that there's optic neuritis due to demyelinization of the optic nerve. But if you do that test with different check sizes and you see that this peak time delay only occurs for the fine checks and not so much for the large checks, then this is a sign that, or at least a high likelihood that this is actually not optic neuritis, because it should affect all check sizes. Rather, it's something at preceding stages. Maybe the vision is just blurry and the fine checks are not resolved properly, and this might result in a peak time delay. I mean, if the checks are still a bit there, but fainter, less contrast because of the blurriness, then this might delay the response. While that slight blurriness does not affect the response to the big check sizes so much. So it's really important to look across the check sizes and say if it's just the small check sizes that are affected by delay, then it's with very high likelihood not optic neuritis. Just as an example, how we sometimes can guess about earlier stages, even if we don't have a recording from there. But generally, it's important to remember that this is a chain of activation. There's one point where I would disagree with what we have seen in the video. But that's maybe the perspective of me as a researcher, different from the clinician's perspective. Because in principle, we could also measure higher cortical processing beyond the primary visual cortex. We just need to use different electrode arrangements. We maybe need to use different stimuli. Then we can actually measure signals that reflect consciousness. So we have talked about attention and so on earlier this week. some stimuli don't reach attention basically, or no, they don't reach consciousness because these attentional filters filter them away. But there are possibilities to actually measure whether something reaches consciousness, or we are at least with measurement very close to that. And so we can measure at various stages. That's basically the message. We just need to use proper stimuli and proper electrode arrangements, and then we can do that. That's of course not what the standard electrophysiology kits do in ophthalmology. That's what we've already heard. With very few rare exceptions, electrophysiology testing is not pathognomonic for any disease. And different places follow different strategies. I've already said that. It's crucial to interpret electrophysiological outcomes in the context of other findings to obtain the diagnosis. And yeah, now we get to the end of my part, and then Heiko Philippin will take over. Electrophysiology assesses the function and thereby complements imaging methods which primarily reflect morphology. That's a very important point if one wants to understand what's the purpose of electrophysiology or the value of electrophysiology. And if people come and say, oh, we have these great OCT machines, they show us everything and so on, they show you a lot, and to some degree they have resulted in electrophysiology being used a bit less since OCTs became generally available, but they don't tell you what the function is. I mean, sometimes if they show that whatever the cells are completely dead, of course there's no function, but if they show some changes in morphology, you don't know, are they still functioning or are they not functioning? And that's something electrophysiology could tell you. And the core question is, what neuronal structures are affected in the suspected disease, and how can their function be measured differentially? That's basically the questions that one need to ask when you do electrophysiology. And my opinion is you don't need to learn a long list of things like if this suspected disease, then do this test, or if you have this outcome, then it is this disease. I mean, that's something that some people try to learn by heart. Yeah, and then they have a long list and don't remember it anymore if on that day when they need it. Yeah, I would rather come from a different perspective and say, if you know the pathophysiology of the disease that is in question, you know whether it's the cones that are affected or the rods or the optic nerve or so, and you know a bit about the electrophysiology tests, then you can actually tell which test to use because you know which cell type you need to test. And also the other way around, if you get a certain result, you know what the cell type is that is affected, and then you can go through the possible diseases and say, okay, if it's this cell type and also this cell type, then it's rod-cone disease, rod-cone dystrophy, for example. Yeah? Or if it's this electronegative ERG, then it must be something in the inner retina. So it could be, and then you start thinking about, okay, inner retina could be X-linked retinoschisis, or it could be a certain type of congenital stationary night blindness or so. So that's how I would approach it. And I mean, me as someone who is not a clinician, I also have my cheat sheets, but they go the other way around. I already know then what the structure is that is affected, and then I don't have so much clinical knowledge. Then I take out my cheat sheet to say, okay, it could be this and this and this. But most of you already have that clinical knowledge, so we don't need my cheat sheets. Yeah, so I then would pass this to Heiko Philippin. And you can now decide whether you ask questions now or after he has had this part of the presentation. Or you ask something while he is setting up. Yeah.
Thank you. So is there evaluation for the difference between an abnormal result and then the artifacts done by the doctors who are interpreting the results or those who are taking the test?
You mean whether there's a difference in how the evaluation is done? Or I don't know whether I fully understood the question.
My question is, you showed us results where there is a line that is not expected from the electrical interferences and then a second B wave because there is probably a blink. Is that done by the doctors interpreting the results?
So normally, I mean, it depends on situation, but probably in your case, when you're not at a center where electrophysiology is done, then probably you would get the results together with a little report, and that report should already take this into account. But then you would have it easier to understand that, and otherwise you might wonder, okay, there's that huge deflection in the curve. Why haven't they written that there is whatever this response, and that would understand, okay, this is probably an eye blink, and therefore they haven't interpreted this as a retinal response. If you're at a center where, like in our case, where electrophysiology is done, then often, for example, the ophthalmologists, they have an immediate look at the curves, basically, or at that summary sheet that we provide. But I didn't have the time yet to write anything. So I would hope, unfortunately it's not always the case, but I would hope that they can interpret it to some degree and at least find like gross problems with recording. And sometimes they do very well, and sometimes then I see when in the draft of their letter that there's something completely odd that they've found, and then I try to alert them that they have written something wrong or that they should double check with what I've written. But generally, in your case, you should get a report that accounts for all this.
Thank you.
So, Heiko.
Okay, so we have about 15 minutes left before we switch the groups. So a lot already, and I just want to wrap up a few things and then focus on the most common this group of diseases which Enyan told me why they use the electrophysiology lab so far. Obviously this might change, but so far he said this group of diseases was the most common indication to do electrophysiology for them. It's not, or can you just move to the next slide? Yeah, thank you. So a 20-year-old man began noticing during his late teenage years that he has problems with night vision. And initially he struggled to adjust when he moved from being outside in the bright light to a dimly lit room, or in the evening walking outside at dusk. He had more and more problems. So he presented to your clinic, thank you, and you checked visual acuity. It was still 6.6 in the right eye and 6.9 in the left eye. And on examination, you saw some in the mid-periphery, some clumps of pigments. You saw already slightly narrow blood vessels, especially the arteries, and the optic nerve head was somehow pale. So what's your guess? Which direction are we heading here? RP, exactly, yeah. So who of you has seen a patient with RP already? Yeah, most of you. It is one of the most common macular dystrophies. And these are also exactly the three, let's say, cardinal signs which you see when you do fundoscopy. Oops, okay, the other direction. And so if you look at the fundus on the left, this is not the same patient. This is just for didactic purposes. I took 2 images. Oh, yeah. So here, unfortunately, you can't see it very well, but you can already see a slightly darker area, which is mainly dark because the surrounding central retina is a little bit light. So this is the so-called bull's eye. You don't always have it, but sometimes you can see it from this pattern of this bull's eye, where people play the game of shooting arrows on this target. And on the right side, and also on the left side, you see what is meant by a slightly pale optic nerve head. Also, again, here on the screen or here on this screen. Here on this screen, actually, you can see it slightly better. And usually, you always compare the 2 eyes. It may be asymmetric. So these are the signs. And then also on the left side, you can see it in an earlier stage. And on the right side, the right fundus, it is more advanced that the blood vessels are somehow attenuated, so thinner than usual. And also what you see on the right picture more clearly are these bone-like pigment clumps in the mid-periphery. So that is fairly clear. So you would tell the patient, okay, this is retinitis pigmentosa. And so what could electrophysiological examination then help in addition? Okay, yeah, just to add one more examination, you would expect, in the classical type, you would expect tunnel vision, so a loss of the peripheral visual field, which is shown here. This is from the Kansky. And just to show now one atypical ERG. On the left side, you see the normal ERG reactions. The box on the left side is the dark adapted standard. On the right side, the light adapted standard. It uses here a blue flash and a white flash. This is also not always done to use a blue flash, but it can be done for certain purposes. And you see here in the second column of the left box, you can see in RP, the signals are more or less the A and B wave, especially the B wave is almost gone, with both types of flashes. And then also for the light adapted, for the 30 Hertz flicker, it is flat, and also the white flash is flat. So this can confirm the disease, also at a relatively early time. Sometimes people do not show these typical clinical signs. Sometimes you might have no bone-like speckles. Sometimes everything looks somehow normal. They still might tell you they have problems looking at night. Or they might be concerned, what about my family? What about my children? And here also you might detect some early signs which might help then if they look for example, if they look for a profession. I remember my son was treated by a physiotherapist who had low vision. And he told me, well, when he was in his teenage years, they already told him, unfortunately, probably in the coming 10 years or 20 years, his vision might be significantly reduced. So he thought, well, what do I like to do, which I might be able to do with low vision. So he decided to become a physiotherapist, where you do a lot of with your hands. It's actually sometimes an advantage. you develop very differentiated senses to treat your patients. So that's why he decided to become a physiotherapist. So in that sense, it can be helpful if you also test family members. Obviously, again, electrophysiology might not be the only test, but it can help you to detect it relatively early. And this is now my last slide. And this is also another reason why electrophysiology is helpful. There are several ways to classify the different subtypes of retinitis pigmentosa. Again, as I told you, it's a group of diseases. It's a relatively large group of diseases. It's also increasing in size. And there are also, I call it RP-like diseases, which look similar, but they are not retinitis pigmentosa. And you can actually drill down to the more specific diseases. This would be a long lecture on itself, but you can, using electrophysiological examinations, you can drill down to be more specific which subtype of RP it is. And this, again, might help in the prognosis and also in the inheritance pattern. So if somebody comes to you and says, well, I'm about to start a family, what about the risk for my children? And if you find out, well, it is maybe just a post-infectious retinopathy, probably there are no signs for any classical retinitis pigmentosa. It just looks like one. You can help the patient that most likely his children will not affect it. Whereas if you find out it's autosomal dominant and AD retinitis pigmentosa, chances or risks are higher for his children. So this is another reason where then electrophysiology can help giving advice to the patient. So this is just in short one example where I think which is relatively common, where electrophysiology could help provide additional information. Obviously, not everybody of you will now set up your own lab, but you could refer patients here, and then if they're able to travel, and if you think it is necessary, and then discuss the results with your patients. So, Medaase, again, thank you very much. Do you have questions, again, for Sven or myself? Another disease which is relatively common, which was I was planning to present, but I thought it's just taking longer, is optic neuritis. Typically, obviously, this where we say, well, the doctor sees nothing, the patient sees nothing, which is usually also enough to get the diagnosis. You do an RAPD, but sometimes in more subtle more subtle variants, and also to follow up the patient, it might be helpful then to do a pattern or to do a VEP or pattern VEP. That's actually another reason, which was already mentioned in the other lecture this morning, to follow up patients, also to see if they are progressing or not. It might be another reason why electrophysiology can be helpful. A lot of types of retinitis pigmentosa, they are stationary. You have them from birth, but they do not move, advance, progress much. Whereas others, they progress over life. They might start later, then they progress over life. And electrophysiology can also help there to follow up patients to see if the disease is progressing or not, while maybe the visual acuity is still remaining the same. So I don't know, if you don't have any other questions, I guess we can have our tea break, and the others will come up shortly. So then you will switch. You will have some practicals downstairs. You will do some electrophysiological games yourself. Thank you very much.